Okay, well, I think people will continue to join in, but I did just want to announce for folks who are on the line now that you are indeed at the IHPS Emerging Scholar uh, lunch and talk. Uh, and we'll wait just a few more minutes for folks to gather. Shivan Mehta is with us today from the University of Pennsylvania, and he'll be our speaker, and I'll give him more of a real introduction again in just a couple minutes. I did just want to let folks know at the outset that unlike how we did our last Emerging Scholar talk, this is a live talk. Shivan is actually blinking as we speak to him, and he welcomes questions during the talk. So feel free to unmute yourself. You have that power to ask questions and interrupt. And of course, because it's Zoom and there'll be slides up, you may need to be a little bit noisy to get attention and interrupt, but that's how we'd like to do it today. I don't know if there's any other, I'll be monitoring the chat. So if someone wants to put something into the chat to ask for interruptions, we can do that as well. Well, my screen is now full up with Brady Bunch chiclets. So maybe we'll get started. That sound good to you? Are you ready, Shivan, to get going? Mm-hmm. Okay, terrific. So welcome to our second of the, I guess this is the 2019, 2020, or is it 2018, 2019 Emerging Scholar presentations through the Philip R. Lee Institute for Health Policy Studies. My name is Dan Doan. I'm the interim director of IHPS, and it is my pleasure to welcome our speaker this week, Shivan Mehta from the University of Pennsylvania. The Emerging Scholars Program is an opportunity for people who are relatively early in their career to have the chance to visit campuses and present their work and get feedback and have the experience of something that looks a little bit like a job talk. It's a program between the University of Michigan, UCSF, and the University of Pennsylvania. And this is a talk that I think was supposed to happen about 6 months ago, but was interrupted by COVID. So we're doing it virtually. As I mentioned just a few minutes ago, the format for this talk is a little bit different than the last Emerging Scholar talk we had. Shivan is with us live, 3 hours ahead of us, and he will be happy to take questions during the talk. So please feel free to unmute and interrupt, or you can put something in the chat and I can help interrupt as he goes along. We're really we're really happy to have you with us today. We're very sorry that you can't be here real and in person, and hopeful that at some point when COVID is a memory, we'll be able to resume some in-person visits and make up for lost time. Shivan is an internist and a gastroenterologist at the University of Pennsylvania and also at the VA in Philadelphia. He's a senior fellow at the Leonard Davis Institute for Health Economics, and folks who know the Leonard Davis Institute know that it's very well known for the depth of behavioral economics and the work that's done there has been groundbreaking in lots of fields. It's an amazing tool, and Shivan is trained both as an undergraduate in economics and also has an MBA from the Wharton School, I believe. So really brings to his work this sort of grounding in this theoretical framework of behavioral economics, but in his work really has a focus on the practical implications and translation of that, and really a focus on practice change. He's led multiple pragmatic clinical trials, and I'm not sure if he's going to be talking about some of those today. And then he also has a couple of very interesting hospital positions as co-director of quality improvement and delivery science, and then also as associate chief innovation officer. So someone who's taking their research and trying it out in practice in multiple different ways and domains, both through pragmatic research and through leadership. Not surprisingly, Shivan was named in 2017 one of the 40 under 40 professional leaders in the Philadelphia region. And we're really looking forward to hearing from you today on the topic of behavioral economics and population-based colorectal cancer screening. Shivan, take it away. Thank you for being here.
Great. Thank you so much, Dan, for that kind introduction. And as mentioned, I was supposed to be there in person, but this is the next best thing, and I'm really excited to be here with all of you, and I appreciate all of your time and attention during this, this time of lots of Zoom calls. I'm going to pull up my slides right now. Okay. And as Dan mentioned, my real area of interest from a broad career perspective is of that overlap between trying to improve the delivery of care locally at our own health system. So how can we develop, test, and evaluate new ways of delivering care that improve population health outcomes? But also, how can we design and to develop different types of trials and evaluation structures to be able to create generalizable knowledge. So not just helping our own health system, but thinking about evaluative approaches to be able to share elsewhere and to do it as rigorously as possible. So today I'm going to talk about an area, a clinical area, obviously of interest to me as a gastroenterologist, which is colorectal cancer screening, how we can increase screening rates on a population level, and how we can apply principles of behavioral economics to that. I do research in other areas, but I thought that it'd be great to kind of do a deep dive into this particular clinical area because I think there's a lot of interesting lessons to be learned that we're starting to kind of try to apply elsewhere in other areas, whether it's breast cancer screening or whether it's hepatitis C screening or remote monitoring or things like that. And so I'm going to talk briefly about colorectal cancer screening. I'm going to talk about new insights from the field of behavioral economics. Importantly, how we can actually apply those insights to healthcare delivery. So I'm going to talk about a few different pragmatic trials that I've done at our own health system or local health systems to be able to evaluate these things. And I think the interesting thing there is that these are projects that are advancing the delivery of care for patient populations there. So we've been working with clinical partners that have immediate goals. They want to increase colorectal cancer screening in their population. But we've been working with them to do it so we can offer it to everybody, but also be able to evaluate that in a rigorous way, and ideally in a very prospective way. And then finally talk just broadly about, various themes related to population-based colorectal cancer screening. As mentioned, if you have any questions or clarifications or things like that, feel free to chime in. I do want this to be conversational if that's of interest to the group. And so, this is just some background about colorectal cancer screening. Colorectal cancer is the second leading cause of cancer death in America if you look at both men and women. And importantly, especially, as we're starting to think about, health equity and anti-racism in our own health system, Black patients are more likely to be diagnosed with colorectal cancer and more likely to die. And it's pretty substantial, that gap between our Black patients and those of other racial and ethnic groups. And that's something that has really persisted. It hasn't really narrowed that much over the course of the past few years. And you can see here, this is the trend of colorectal cancer over the course of the past few decades. And you can see that new cases and deaths are going down. And so in some ways, it's a bit of a success story in that, some of it's related to things like tobacco cessation, because we know it's associated with all different types of cancers. A lot of it's associated with cancer screening. So colorectal cancer screening, there's multiple trials and high quality of evidence showing that it can reduce colorectal cancer specific mortality. And there's a lot of evidence out there showing that, and we can identify early stages of disease and even prevent it if we take out polyps. And then finally, there's obviously a lot of therapies out there. So when people are diagnosed, particularly in early stage, there's a lot of great things such as surgery, radiation, and chemotherapy that are very, very effective. I'm not going to talk about those aspects of it, but it is important to understand that there's a whole cascade of things that we can do to improve outcomes. And despite all of the evidence we have and a lot of the success we've had, colorectal cancer screening rates still remain limited. So they have been increasing over the course of the past few years, but you can see here that it's still about 60 to 65%, depending on which study you look at. And that is lower than rates of cervical cancer screening and breast cancer screening. So there is an opportunity to really bridge that gap. And it relates to, I think, some of the things that I'm particularly interested in is when you have strong evidence that something works, how do we make sure that all of our patients can benefit from that? And there's a lot of different system factors, clinician factors, patient factors related to that. And so when we think about why colorectal cancer screening those rates are lower than other screening activities, it's not that surprising if you understand how we do screening predominantly in this country. So most patients that get colorectal cancer screening get it through screening colonoscopy, which is very effective. It's what I spend a lot of my clinical time doing. But if you look through the process from the patient perspective, it is pretty dramatic. I think us as gastroenterologists, we see them when they come in and when they come in the office, but we don't realize all those different steps it takes to get screened. First, you have to know about it, and it's typically happening through a primary care doc visit, and often through a visit. So your primary care physician or clinician has to recommend screening to you. You have to, often get an order. You have to figure out where to get screened. So you have to make a decision of, which screening endoscopy site you want to get screened at. Then you have to schedule an appointment. Sometimes you have to see a gastroenterologist for an office visit before that appointment. You have to, drink the prep, have a friend or family member come in, take a day off from work, have them take a day off from work, come into a procedure that is not seemingly pleasant. Patients do get sedation, but still, it's not something that anyone is very excited to get done. I think screening colonoscopies are down there with Congress in terms of the things least liked by society in America. And then you have to sort of follow up, and there's a lot of fear related to cancer diagnoses. And so I think what we've learned is that any of these steps, if anything breaks down, then this patient will not get screened. And so a lot of our efforts are really focused on all those different aspects of the cascade. What can we do to help people to get screened? And particularly in the COVID area, there's even more concerns about colorectal cancer screening. So this is actually data from our own health system, from Penn Health System, basically tracking the rates of colonoscopy at our 4 endoscopy sites across our health system. So you can see it's pretty consistent over time. And then for good reason, during the COVID pandemic surge, that really went down to just about nothing. We were only doing procedures that were really life-threatening. They had active symptoms. And since then, it's actually come back quite nicely since around May. We've been very deliberate about it. We do COVID testing for everybody, and I think we're about 90 to 95% of what those rates were before. But I think there's a few things that are worth noting. One is that when we looked at the data for our population, these are people that were already scheduled to get colonoscopies. So these are people that had already sort of agreed to get colonoscopies. We found that Black patients and Medicaid patients were less likely to get rescheduled and less likely to show up, which we thought was pretty dramatic and interesting. We're trying to understand some of those barriers, so we're working on that aspect of it. And then the second part is that even if we get to 100% of what we were before, we still have a bunch of patients that are sort of have that gap of screening, because there's basically about 3 months where people were not getting screened. And so even if we catch up to normal, there's a bunch of people that, that we still have to catch up on screening. So if we really want to catch up on screening rates, we actually have to get to higher than 100%. And we actually looked at our data of how many colorectal cancers we diagnose or we see at our health system. We found that there's a large number of undiagnosed colorectal cancers at our health system, about 147. Some of those are related to people that were referred to our health system. So as an academic medical center, we get referrals from the community, and some of those are related to people that get screening at Penn. Either way, there is this worry that once people sort of break that habit of getting screened, and once they get sort of spooked by COVID, or they get told, they hear from their provider that this isn't that important compared to other medical issues, the worry is that they may not come back until much later, but most importantly, they may never come back. And so I think that's the worry that we have right now. And I think one aspect of that, particularly during the COVID era, is that we can't rely on people coming into office visits to get offered screening. And I think that's a big principle that we've really worked on before, and I think we've learned from a lot of different areas. But particularly in this environment, we can't rely on office visits or virtual visits with primary care docs. We have to directly and proactively do outreach to patients. And I'll talk a little bit about how we do that and ways to enhance that. So as we think about barriers to screening, there's obviously patient level factors, family factors, close community and household factors. So patients ultimately have to get the screening performed. They have to agree to it and participate in it. The clinician typically has to order it or at least be aware of it, so that there's another clinician factor. And then finally, there's different health system or community level factors, whether there's policies related to having insurance or not, whether there's cultural norms related to screening in certain communities. So that's a big concern in many communities in our area, that there's a lot of fear and concerns about colorectal cancer and colorectal cancer screening. And tied to all of those things are interventions. So when we think about what might work to increase colorectal cancer screening rates, it's really these multi-level interventions, things that target the patient, clinician, and the health system around us. And so one project that I did as part of my thesis during my fellowship was related to a policy that came out of the Affordable Care Act. And this was a principle called value-based insurance design. So the idea is that for things that are perhaps low value, like surgery for back pain, you might, or imaging for back pain, you might have higher cost sharing, or even let's say like PPIs for certain things. You might have higher cost sharing because you want to sort of reduce overutilization. But for things that have high effectiveness and cost effectiveness, like colorectal cancer screening, you have no cost sharing. And so the idea is that if you do that, if you do things like that, you could potentially increase the number of people that get screened. So I think all of us were very excited about this, and we're still excited about this policy. But what we wanted to do, what I wanted to do during my fellowship is actually to see if this actually had an impact on screening. And so we looked at a small business population at a large national insurance company. And what was interesting about this was that it allowed us to have a sort of natural control group, because there's a lot of secular trends in screening rates. So screening rates, as I've shown, have sort of been going up over time. So if we just look at it before the policy and after the policy, it would look like it's increasing, even though it may not necessarily be from this cost sharing policy. So we found that in this small business population, some of them were grandfathered, which meant that they did not have to adhere to this policy change. And some of them were not grandfathered, which meant that they did have to change that policy change. So what we found first is just to see if they had a difference in cost sharing. And you can see here that the control group, which is the grandfather group, had similar cost sharing over time, but the non-grandfather group, or the intervention group, had a reduction in cost sharing. It wasn't down to zero, so I'll get to that in a little bit. But what was even more interesting is that because this was a high deductible plan, they had about $600 in cost sharing, which is a pretty dramatic amount. $600 is a lot of money to get a colonoscopy for anybody. And so then we tried to look and see if there was actually a difference in utilization. We found that there was no difference in utilization. And this was early after the policy. And since then, if you look at the high quality studies, there's really just a marginal to no benefit of these value-based insurance designs for colonoscopy. And so we tried to kind of hypothesize what were the reasons that this did not have its sort of intended effect. And one of them was that only 60% of the colonoscopies were coded as preventive. So many of them were still getting cost sharing. We're still trying to change that. It requires, as I mentioned Congress before, it requires an act of Congress to change that, which isn't happening anytime soon, despite a lot of efforts. But more importantly, I think many patients were likely unaware of the cost sharing amount. So even if you talk to our practice managers, if you talk to the clinicians, we have no idea how much patients are charged, because there's so many different insurance types. Even within one of our local Blue Cross insurance companies, they can't even tell us, if you're in this plan with this company, you get this. If you're in this plan with this company, you get this. It's incredibly complicated. It's an infrequent event. And so we know that this type of value-based insurance designed for medications can have some benefit. That's because people are getting their medications filled every month. For colonoscopies, the people that this was targeted towards are the people that have never had screening before, so they have no idea what the cost sharing is for a colonoscopy. And then finally, there's this concept that patients respond differentially to cost sharing increases and decreases. And that goes against sort of neoclassical or traditional economic theory. So I was an economics major as an undergrad, and we always were taught that, $10 equals $10, depending on how you offer it. And so that's why we sort of, looked to the field of behavioral economics to kind of try to understand why this didn't follow exactly what we thought. And so obviously, there's a lot of books that are written about behavioral economics. 2 Nobel Prizes were were awarded in the past 2 decades for a lot of these principles. And I think the main concept here is that different from traditional economics, humans do not necessarily act rationally, which I think to psychologists isn't new news, but to economists it was. But they also do so in a very systematic way. So they have these heuristics or biases that happen sort of over and over again. And many of these are shortcuts. We can't, think about every decision we make. And so we have to have this sort of automatic part of our brain as a shortcut to know how to tie my shoes or how to ride a bike or, how to drive a car or things like that. And the problem is that in that automatic mindset, for the most part, it's actually good, but in some areas it actually impedes us. And so there's a few different predictable biases or heuristics that we know, happen over and over again. One is this concept of status quo bias. Humans have inertia. We have a preference to maintain the default or the status quo. When we have an option, we'll just go with what the sort of standard option is, and it takes a higher degree of evidence to overcome that. We have loss aversion. So just as I mentioned before, we weigh losses more heavily than gains in an asymmetric way, which is very interesting. So if you take something away from someone, they despise that more than if you sort of never give it to them in the first place. Present time bias, we're obviously more focused on things that happen today as opposed to the costs that happen down the road. Colonoscopy is a great example. It's a pretty high cost today, and the benefits that you accrue will be non-tangible and probably 10 to 20 years down the road, and you'll probably never know that you were actually benefited by having a colonoscopy. And then finally, framing effects. The framing of the messages can alter response. And so this pertains to not just patients, but also clinicians. So this is a study done with a few colleagues looking at the rate of ordering of colon cancer screening and the rate of completion of colon cancer screening, depending on when during the day you visited your primary care doc. And we basically found a 10% decrease in ordering and completion if you went at 4 or 5 o'clock as compared to 8 or 9 o'clock. There shouldn't be anything different about these patients. We controlled for a variety of factors. And we think there's probably a couple of things at play. One is that patients or clinicians are probably rushed at the end of the day, but there's also this concept of decision fatigue. When somebody's making decisions over and over again, they get worn out, they just get sort of overwhelmed by these decisions. And so they end up making, having sort of more of a cognitive deficit, and they're not able to kind of think through all the things that they want to think through over time. So when we think about how to overcome these, we want to target both the clinician and the patient in some of these efforts. And so I'll give an example that is not particularly relevant today. I wish it were. And I can only yearn about, and think about the days when we could travel. But, if you could imagine purchasing, when you buy your tickets online, you buy the ticket, and then at the end of it, the airline wants to sell you trip insurance. So they actually make a good amount of money off of it because, how much you spend on it is sort of less than how much they dole out in terms of, paying out when there are issues where you need to redeem that trip insurance. And so they have an interest in sort of getting you to participate. And in the traditional, way of doing it, it was sort of an opt-in at the end. You buy the ticket, then you have to click through a few different screens where you get offered trip insurance. Nobody clicked on it. They just wanted to, check out and move on. And so, they a lot of these companies, and they do this not just in airlines, but pretty much every other aspect of our life, they realize that they need to leverage some of these behavioral science principles to get us to at least consider purchasing it. Now, it doesn't force us to buy it, so they didn't just sort of automate it, so they didn't add it into the price. But so they still give us choice, but they know that there's a lot of things that you can do to kind of increase participation. So the first thing that was interesting is that they moved from an opt-in, where you have to sort of click on a box, to essentially what we call an active choice. So you have to decide between saying yes or no. So we know that typically moves the needle a little bit. The second thing they did is something called enhanced active choice. So they made the choice that they want you to choose more attractive. So yes has, green coloring around it. It's bolded. It describes sort of the good benefits of it. And then they also, for the no option, they make it seem less palatable. So, you have to click on no, I'm willing to risk my $865 on the trip. So that's one aspect aspect of it, which is changing the choice architecture. The second aspect of it is how they leverage financial incentives. So they basically say it only costs $56 to purchase this, but you could risk $865 if you did not purchase it. Another aspect of the sort of financial incentive part is to have an anecdote. So they described that, Mary got $468 back when she canceled her flight. So you could be like that too. So they know that people respond to anecdotal stories much more than they respond to large amounts of data. And in this COVID era, we can certainly appreciate that part of it. And then finally, social norms. In a couple of different ways. They had obviously the example of Mary, but then the other example is that they described that 27,912 customers protected their flight in the last 7 days. So, humans want to, do what other humans are doing. And so if you see that everyone else is doing it, that you want to do that as well. A great example is for a lot of energy companies. They tell you what your usage is, but they also tell you what your neighbors are using because they want you to sort of participate in that. Is there a question?
I was actually posting to encourage people to ask questions, but I actually also have a question.
Okay.
Which is just picking up on your example. When I see things like this, I immediately think, oh yes, they want me to buy the trip insurance because that's how they make their money, which is something you just said. And here they are making it look very attractive, which makes me even more suspicious. I'm curious if there are those kinds of learning effects that take place where consumers then alter their behavior because they're getting signals about what the seller is interested in having them do. And if that's something that also needs to be thought about in the context of healthcare, where people may be suspicious of, Dr. Mehta is going to make, $1,000 if I allow him to do this procedure. And maybe that's not such a great idea.
Yeah, and I think that's a great point. I think there's two comments related to that. One is that what's interesting about the field of behavioral economics is even when you tell people that something is used to make you change your decision making, people still do it. So that's one aspect of it that we know to be true. So even if I know that they're trying to leverage this to get me to buy something, I'll still participate. I'll still do that. This concept of reciprocity is a big one. Charities, and I'll get to charities send you like free stamps or a free card. I know they're using it against me, but I still feel guilty about it. So I still wanted to give them something back because it's a very strong social norm. But there is that trust factor that I think is important. I think that the other piece there is that even if something works in one domain, it doesn't mean it'll work in other domains. And so that's why it is important to be able to evaluate this. So just because something works to get people to vote or get people to buy something doesn't necessarily mean it will get people to get mammograms. Because there is a lot of trust factor involved and context has a lot to do with it. And I think that highlights, more the reason that we can't just take these things. It's not like, statins work and you give statins to everybody that's eligible for it. You have to understand context around it. You have to evaluate to see if it actually works in that context. So when we implement some of these behavioral science nudges or interventions, it is important to evaluate it. So I think that's a great point all around. And so choice architecture, financial incentives, social norms. And so the first thing I'm going to talk about a little bit is choice architecture. And historically, most of what we do in healthcare is opt-in. Do you want to get colon cancer screening? Do you want to do this test? Do you want to sign consent for this? And we know from retirement accounts, so when they switched from opt-in to matching for your 401k or 403b to opt out, it increases participation by about 30% to 60%. We know it works related to organ donation. So countries that have opt-out organ donation have higher participation. And so the question is, can you move things from opt-in to opt-out to have sort of a stronger nudge? And in general, you want to do that for things that are incontrovertibly effective. So I would put colon cancer screening up there. I would put things like flu shots for eligible people up there. For things that you're not so sure about, then I can certainly imagine that it could, should be opt-in or shared decision making or things like that. And of course, mandatory is a even stronger nudge, but it has some drawbacks to it, as we're seeing with a lot of mandatory things going on today. For example, at our health system, we have to have a flu shot to be able to work here. Otherwise, we can't continue to work at our institution as healthcare workers. But a lot of other things, you can imagine you can't do that just from an ethical standpoint or even a patient receptivity standpoint. And so I think what's powerful about opt-in, active choice, opt-out is that it maintains choice. It's this concept of libertarian paternalism where people can still choose, but we're guiding them in the direction because, we, physicians, healthcare workers have actually looked into the evidence of this, and people are coming to us because they want our opinion. They're not coming to us to, put that decision making to them necessarily for everything. And so we actually tried to evaluate this for an experiment related to increase in colon cancer screening rate at one of our primary care practices at Penn. So we identified 314 patients who were offered colonoscopy, over and over again, still did not participate. So these are people that were still not up to date on colon cancer screening. And then, we thought about the sort of conventional way of offering them screening, which is to say, send them a letter, send them a message, and then have them contact their primary care doc or have them respond to that message saying, yes, I want to get a mailed fit kit. And so that's a very, intuitive thing to do. We ask the patients before we offer to them. And then we compare that to an opt-out approach where we send them that same messaging, but then they get a postcard to basically say, I do not want to participate. So they have to opt out. So it actually takes more activation energy. So it's changing that default from opt-in to opt-out. And just by doing that, we actually tripled participation. Now there is a cost to sending out more of these fit kits, but it's relatively trivial. It's maybe $5 or so. And we found it to be, pretty cost effective in terms of, or at least, advantageous from a cost perspective as compared to having people talk to these patients over and over again and reach out and things like that. So that was a great way that, moving from opt-in to opt-out can increase participation. And we've seen this in other contexts as well. We tried this again at a different setting, but this time using text messaging. So this was a community health center in the Southwest Philadelphia area. And so this patient population is very different than our patient population. They have about a 19% colorectal cancer screening rate. They have socio-demographic, they have social issues. They have, they may not have employment or a place of residence, so they're a very transient population. And so the conventional thing that the clinic was doing was using these text messaging platforms, which are great because we know that, just about everybody has some kind of cell phone where they can get text messaging. They may not have a smartphone. They may not even have an address. They may not even have, Wi-Fi connection, but many of them do have text messaging. And so what they were traditionally doing was basically sending them a text message saying you're overdue for colon cancer screening, call us to discuss your screening options. And then they would sort of offer them a fit kit. They'd probably have to come in. We tried an opt-in approach where they said, please text back yes to receive a kit. And then we tried an opt-out approach. We tried the opt-in approach because we wanted to see if we could sort of save fit kits for the clinic because they may not have the resources to be able to send that out. And we found sort of similar results, a smaller response rate, which wasn't surprising given that it's a very different patient population, but the traditional outreach basically didn't work. And 3% is even generous. It wasn't clear that they had any effect. The opt-in approach had a 12% response and the opt-out approach had a 20% response. So similar types of things that we see from moving from an opt-in to an opt-out approach. And we're applying this to other types of screening as well.
So Shivan, there are a couple of questions that have entered in the chat, although actually there's one question in the chat and then Jeff Belcora had a question. I don't know if he wants to unmute and ask from some of the previous materials who just presented. Mm-hmm. Liz Zhang also had a question in the chat. But Jeff, do you want to?
Yeah, well, sure. I was just waiting for a natural pause. If this is a good pause, we can do it here. Thanks for this great talk. And on a personal note, is Roy Rosen still involved with innovation at Penn? He was a neighbor and friend of mine here at Stanford.
Yeah, absolutely. No, I work with him every day. So I mean, he's one of the leaders of the Innovation Center. That's fantastic.
Yeah, please tell Roy Jeff Belcora says hello.
I will.
So I have a kind of an existential question about your project, because I think once you accept the mission, I think the choice structuring process that you're using makes a lot of sense. Over the years, I've asked myself as a decision scientist whether I should be doing colorectal cancer screening. And Ralph Keeney wrote about this in his book, Value Focused Thinking. And at the time, he concluded that it was better for him to take whatever time he was going to invest in colorectal cancer screening and go do some exercise from a health point of view. And that was because at the time, there was no study, no evidence that colorectal cancer screening reduces all-cause mortality. So there's a lot of evidence that it may reduce death from colorectal cancer screening, from colorectal cancer. But really, as you know, evidence-based scientists, we want to be focused on all-cause mortality and look for interventions that reduce all-cause mortality. So is there better evidence these days that this is really a public health intervention that merits a slightly more paternalistic approach?
Mm-hmm.
What's your update on that?
Yeah, no, I think that's a really great point. And I think most of the things I try to focus on are things where most people believe that there is evidence and we just want to get people to do it. Things that we're not so sure about, you know, I wouldn't even touch prostate cancer screening, things like that. And so you are right that there's not any randomized controlled trials showing all-cause mortality. There's a lot of, you know, observational studies, you know, since then. So there's randomized controlled trials showing that FOBT can improve outcomes and, you know, colorectal cancer specific mortality. There's actually a couple of RCTs focused on flexible sigmoidoscopy. The challenge is that, you know, nobody wants to invest in these sort of the larger studies that would sort of answer those questions. And so it's a, you know, very, you know, it's a good point that, that might be the case, but there is a lot of observational data. There's lots of data showing that if you can get more people to get screened, you have sort of reduction in sort of different types of mortality. The argument I might make is that if that's our evidentiary standard, then there's very few things in medicine that we're doing that have much effect on people's outcomes. There's I mean, there's more evidence about colon cancer screening than breast cancer screening, certainly than prostate cancer screening, possibly than lung cancer screening. And so I think these are all sort of important questions from a decision science standpoint in terms of what we offer.
Yeah, thanks. This is friendly fire. I mean, I think there may be other reasons, especially around the disparity issue, for people to be engaged with the health system and hopefully for, you know, some screening to represent a touch point that can perhaps be leveraged into other, you know, health benefits and health awareness. So it's a complex, you know, multi-dimensional issue. But I was curious, you know, whether there had been any change in that kind of evidence standard. And I agree with you. At a certain point, people start to believe the logic of observational studies, et cetera, and it becomes very hard to rally the muster the resources for definitive randomized studies, you know, over a very long term, involving a large number of people, to make this, to really establish whether there's a benefit or not.
Yeah, especially with the control groups too. I mean, the studies people are investing in now are comparing FIT to colonoscopy. So
Yeah.
there's a big study in Europe and a big study at the VA, you know, the confirmed study comparing, you know, FIT to colonoscopy, but there's not as much appetite for like a true RCT, you know, where you're comparing it to a placebo or not getting screening.
I mean, as a consumer advocate, I would encourage you to air these issues that, you know, as part of your work and as part of your education of the public, that there is a leap of faith in going from, you know, here's what we believe based on some evidence, and, you know, based on that evidence, we really want to nudge you in these directions and nudge the population in these directions. But I think sort of rather than, I was going to say pretending, that's the wrong word, but rather than acting as if, you know, this was a rock solid foundation, I think it's helpful from a trust in science point of view to say, hey, look, we're making good faith efforts based on our best interpretation of the data. But if you're looking for, you know, certainty or definitiveness, it's not here. So it's a larger issue. Can the public sort of have the nuance to appreciate that point? And I think that's my hope.
So Jeff, I'm gonna nudge us along in the talk. There are actually some other questions in the chat, but I think.
All right. Thanks a million. Very
yeah. Thank you.
Great stuff.
Point.
Thank you.
Shivan, I think probably you should take it away, and I'll ask folks who have posted things in the chat to unmute themselves once we get a little further. But I'm concerned that we're not going to get to what you have still in store for us.
That sounds great. And so another aspect of choice related to cancer screening or colon cancer screening is that there's a lot of options out there. So the U.S. Preventive Services Task Force, which is probably the most conservative body, says that there's 5 potential options out there: colonoscopy, FOBT or FIT, multi-targeted stool DNA, CT colonography, and flexible sigmoidoscopy. which is enough choices to begin with. And if you talk to providers and clinicians, they all have sort of differing opinions. Some of the societies have said, to simplify things, we basically think that colonoscopy and FIT are sort of the two options that we should offer. If you want a potentially more effective, but more invasive test that you only have to do every 10 years, then you can pursue colonoscopy. If you want to pursue a less invasive, but one that you have to do sort of every year and maybe not as sensitive, then you can pursue, some kind of stool testing. But how we offer that choice still remains to be seen. So there's actually not much evidence of, which you should offer first and how you should offer it and in which context you should offer it. So what we tried to do is actually evaluate if offering a choice of colonoscopy or FIT could increase screening rates compared to just offering colonoscopy alone. So the standard option at our health system is just offering colonoscopy. That's what most primary care docs do. They sort of believe it for a variety of reasons. They also don't have to worry about it until every 10 years. And so we sent, one group just outreach about colonoscopy, and we gave them direct access to get a colonoscopy. They didn't have to make an appointment or anything like that. They just can schedule it directly. The second was offering colonoscopy. If they did not respond, we offer them mailed FIT, which is what called sequential choice. Many people do this in this country. And the final one is offering both together. You could do colonoscopy, you can do FIT, and we sort of describe the pros and cons of both of those. And I think we sort of intuited that sequential choice and active choice would have higher participation because you give them different choices, and FIT is sort of easier to do. What we found was interesting and sort of against our hypothesis. We found that there's about a 14% response rate to colonoscopy only, 17% response rate to sequential choice, and 20% response rate to active choice. So it was not statistically significant. It may have been underpowered, but we believe that the response rate was going to be something like 10%, 10 percentage points or so. And that's because if you just offer patients FIT, you have about a 30% response rate. And this was based on 2 other trials that we ran. And so the thinking was that if you send someone a FIT kit alone, there are 30% of people respond. If you send them a FIT kit, but say you can also get a colonoscopy, then the people that would choose colonoscopy would get the colonoscopy, the other ones would get FIT. And what we found is that there's a substantial portion of people that chose neither. So if you offer this active choice compared to FIT alone, a bunch of people just said, I can't decide, it's too much for me to think about. Let me sort of defer that decision making. So that's one part that we learned. The other part is that how you offer choice can dramatically change the participation rates. So if you offer colonoscopy alone, not surprisingly, 91% participate in colonoscopy. If you offer sequential choice, 52% choose colonoscopy. If you offer active choice, 38% choose colonoscopy. So subtle differences in how we offer these testing modalities can dramatically change participation. So that's something that's important for us, particularly as we think about these types of outreach where, if you have a captive audience and you're talking to them in person, you can explain all these pros and cons and studies and things like that. But when you're sending things to people when they're not seeing you, which is typically a more effective approach or a complementary approach, you don't have the ability to kind of go through all these nuances. And so we sort of sought out the literature to understand why. And there's a really interesting study from Sheena Iyengar from Columbia Business School looking at the choice of jams. And so what she did was she did a randomized study of a supermarket. At a certain time frame or one day, they offered people 6 choices of jams. And then the other day, they offered 36 choices of jams. So I think intuitively, we always think more choice is better. That's why we go to Amazon. That's why we want, 20 different flavors of ice cream. We want to be able to choose between all these things. And that did hold true when you look at how many people looked at the store aisle. So for 6 choices, 40% of people looked, and for 36 choices, 60% looked. But when you looked at how many people actually purchased something, which is what the supermarkets and the companies actually care about, only 2% purchased when you had 36 choices and 12% purchased when you had 6 choices. And they basically sort of, there's this concept of choice overload that they describe, which is that if you have people offer too many choices, they may not choose any of those things because you're just kind of thinking about all the different brands of toothpaste. I don't know the difference between Crest and AIM and Colgate, and so I may choose nothing. And they hypothesize that there's more choice overload in situations where there's more uncertainty and less knowledge about the different choices. In our case, even 2 choices might have decreased participation. And we think it's because, nobody wants to get colon cancer screening. People, want to get jam and they want to have certain types of flavors of ice cream and things like that. So it's just something for us to think about as we want to give people informed choice. But if we give people all sorts of different options, they may actually choose nothing, not because they want nothing, but because they can't even make a decision about it because we're just overwhelming their sort of cognitive load. A last experiment we did, I'm just sort of checking time, so I'll go through relatively quickly, was looking at our employee population. So when we looked at our employee population a few years ago, these are people that work at Penn Medicine, which is an academic medical center. We found that our colon cancer screening rate was no different than the national average. We had about 60% participation in our employee population, and the national average is about the same. Despite the fact that many of these are healthcare workers, many of these are nurses, they have good insurance, they have access to care, they typically don't have as many financial issues. And so what we found is that many of them knew about it, many of them intended to get screening, but they sort of put it off and they deferred it. And one of those reasons is that a lot of them don't even have a primary care doc because they're relatively young. And if they need to see somebody, they would just go to a specialist, or they would sort of, figure out ways to manage it or, check their blood pressure or something like that on their own or in the practice. And so we created a direct access phone line. We also changed the choice architecture in it. And so when we gave them this web form that allowed them to basically say if they wanted to get screened, when they wanted to get screened, and then someone from our call center will call them back. And so the first choice architecture was, yes, I'm interested in this VIP service. Then if they selected no, they said, no, I do not want to reduce my chance of dying from colon cancer. So this concept of enhanced active choice, and we found that more people clicked on yes, and this was just an early small experiment, if you offer this enhanced active choice as compared to just a traditional active choice or even an opt-in. So we moved that to a larger trial because we wanted to see if people actually get the colonoscopy done. So we took 2,250 employees. A third of them got just usual care, which we thought was usual care at the time, which was just a direct access phone line. A third of them got active choice where they got that web form, and then our call center staff would reach out to them, and a third of them got a financial incentive of $100, and that's because most employers across the country offer even more than $100 of incentives to know your numbers, check your blood pressure, and do all sorts of different sort of health promoting activities. So we found that active choice was no better than usual care, which was surprising. And that's because people were just playing phone tag. So even though a lot of people signed up for it, the call center reps couldn't get a hold of them because people just don't answer their phone anymore. And this was a few years ago. I would imagine that is even more so today because there's just so many robocalls out there. And then the financial incentive did double participation. So this was the first study to show that a direct financial incentive could increase participation. I think the interesting thing here is that the $600 incentive that where you take it away from cost sharing had minimal to no effect, but $100 direct incentive framed and messaged a different way where sort of they give you a gift card did have an effect, basically showing this sort of concept of how $100 doesn't equal $100 necessarily unless you frame it in certain ways. And then we looked at some other studies. So this is a study from Jeff Colgren, one of my colleagues who's now at Michigan, where they offered a $5 incentive to veterans to basically pick up and return their FOBT kits. This was a few years ago. And they found that he basically tried to frame a $5 incentive in different ways. Either we give you $5 if you participate, you get enrolled in a 1 in 10 chance of getting $50, or you get enrolled in a 1 in 100 chance of $500. And the only one that he found to be more effective than a control group was this 1 in 10 chance of $50, basically showing that people may tend to overweigh their chances of winning sort of a higher incentive. So they get enamored by the $50, just like people get enamored by the millions of dollars you can get from signing up for like the state lottery, even though you may not necessarily get that benefit back again. We actually tried this in an outreach study, and I think this is the importance of context that Dan was describing. And so we tried sending them a $10 incentive, which is even more. One of them was just a conditional incentive. We give you $10 if you mail it back. The second was a lottery incentive of a 1 in 10 chance of $100 if you mail it back. And the last one was we just mailed them the $10 incentive. And this invokes something called reciprocity, where if someone gives you $10, you feel like you want to return in kind. That unconditional incentive had the highest effect, but none of them had more effect as compared to the control group. And we think that may have to do with the fact that a lot of people are, if they're going to respond to the mail fit, they're going to respond. The people that didn't may need some other type of sort of incentive or outreach, probably just a conversation with somebody to sort of describe the pros and cons of screening. So just highlighting that even though things might work in other contexts, it may not work in the context that you're thinking about, which is why it is important to kind of evaluate these things prospectively. And so when we think about designing effective financial incentives, they need to be simple and easy to understand, salient when decisions are made, not bundled with other incentives. Things like lotteries, losses, regret, and reciprocity can have more impact. And just an example of something we did, we ran a lottery for people to take their medications every day after a heart attack. And we basically invoked regret. So if they win the lottery but didn't take their medicine, we actually tell them that they could have won $50. And that's this concept of regret. And people absolutely dislike that. And so we find that it actually motivates them to kind of participate the next day after that. So broadly, as we think about scalable population health interventions, I think we all can sort of acknowledge that we can't rely on primary care docs in a reactive visit-based setting to achieve a lot of these population health outcomes. It needs to be a team-based approach. We need to be proactive. We need to do a lot of these things outside of a clinic visit, particularly during the COVID era. But it can't just be people calling them to sort of get them to participate, because those are very, very costly from an efficiency standpoint. So technology, things like text messaging, smartphones, patient portal messaging can make these things much more scalable. We can send 1,000 messages via text messaging immediately at minimal incremental cost. Behavior change is important. We have to think about both the clinicians and the patients and even family members to understand how to encourage behavior change. And of course, care redesign is important as well. Moving things from the clinic setting to the office to the home setting, changing who does what. Often we find that community health workers or patient navigators can actually be more effective at encouraging colorectal cancer screening as compared to even physicians that may spend a lot of their time doing this. And so we're also applying these things to things like hepatitis C screening, things like liver cancer screening for patients with cirrhosis, breast cancer screening, flu shots, things like that. These are some of the same principles of things that are evidence-based and trying to think about how to sort of bridge that behavior gap. So in conclusion, there's a great opportunity to reduce the burden of colorectal cancer with tools that we have. Behavioral economics offers suggestions for how to nudge patients towards the healthy option. This is not just patients, but also clinicians. We have to understand context, we have to understand effectiveness, and also think about the ethical implications of it. And we also have to think about, from a population health standpoint, how we can be much more proactive and basically take things off of the primary care doc's plate, not put more things on their plate, because there's enough to deal with. And we can leverage teams and technology and different types of communication, video visits, remote monitoring, text messaging to enhance a lot of the things that we're doing today. So I'd like to thank a lot of my collaborators. These are students, trainees, and colleagues that I've worked with on a lot of these studies. The Center for Healthcare Innovation, where I'm based, where I spend most of my time, as well as the Center for Health Incentives and Behavioral Economics, as well as a lot of these funding sources to help support this work. Thank you so much for your time and attention, and I'd be happy to take some of the questions.
Great, thank you. That was tremendous. I'm actually going to see if maybe Grace would be available. There are a couple questions. She had an interesting one, I think, for a more immediate follow, and then Justin White also had posted a couple of questions in the queue. So we'll see if we can get them both in.
All right, thanks, Dan. Shivan, thank you so much for a really interesting presentation. I was just curious. Some work I do is in the area of shared decision making, and so the philosophy of shared decision making is you're presenting, options for patients to consider, and but your descriptions of the choice, things like choice architecture and behavioral economic approaches have to do with basically influencing the choice in some way, right? The way you set things up. And I guess where sort of philosophically do you draw the line at coercion? Because it seems like with the colonoscopy intervention, colonoscopy was sort of the most desirable choice. You set it up so it's the most desirable choice, and no screening wasn't a choice, for example. And so I guess I'm just wondering, what is sort of your perspective on that?
I think those are great points. I think that many of these things are complementary to what's going on in the clinic setting already. So I think because we're focusing on primary care populations, most of the primary care docs are talking about it or people have heard about it. So we certainly want to engage in a lot of that. I would say that shared decision-making is even more relevant for things where we're not really sure what the right answer is. You know, do we put a pacemaker in, things like that. For things like getting a flu shot, I would sort of shift in the direction of, you know, people should just get this done and we should reduce barriers for it. So I absolutely appreciate that. I appreciate the value of that. I think what we've learned is that everything we do in life is nudging us in one direction or another. So choice architecture exists already, whether it's in the electronic health record, whether it exists in how people choose to get screened, whether it exists in, you know, one doc will offer FIT testing, the other doc will offer colonoscopy. And so I think it's really just taking advantage of the fact that this already exists in the world today. It's just a matter of, you know, understanding it, guiding it in a direction that we can sort of collectively agree upon. And also understanding sort of like what works and what doesn't work. You know, it doesn't, because there's a lot of situations where, for example, drug companies would change the choice architecture of Epic to get people to prescribe more opioids. So those are all things that we absolutely have to be aware of. And I would hold this to all those same standards. This shouldn't be some person in a basement making these decisions. These are collective things that we make as a health system. So when we do these things, we're working with clinicians across all of these practices, the primary care docs. We're not just like, you know, inserting these nudges with nobody knowing about it. So I think that those are all great points, and we do have to think about the ethical implications as well.
Thank you.
Dan, should I go or are we going to end?
Yeah, why don't you go ahead, Justin? I actually need to jump onto another meeting myself, but I'll take your question and Shivan's answer off the air. Wonderful. Thank you for being here, Shivan.
Thanks.
Yeah, I had a couple questions, one in the chat, one not, and you can either answer one or neither or both. So the study about colonoscopy only versus sequential choice versus active choice, I was a little surprised you invoked choice overload as a possible explanation there, since it's really just a couple different options. And I was wondering if it could be something about the perceived efficacy of colonoscopies versus FIT. That was the first question. The second question just being about where the control did best versus the different types of incentives, whether there might be a peanuts effect at play there, since it was only $10.
Yeah. I'll get to the second one. Yes, absolutely. Although when we actually did talk to patients afterwards to ask them, you know, about the incentive. And I think what we learned is that there's a subset of patients that are like, yeah, I'll just do this. And I think what we realized is that financial incentives probably aren't that effective in a lot of realms, you know, having done a lot of these different studies, and it's probably not that sustainable. People aren't so excited about it for lots of different reasons. But actually eliminating friction can be even more effective. You're making it super easy for people to get, like basically what Amazon does. You know, every click they know is going to get you not to participate. So if you make it one click, then all these people will buy it. So by mailing it to their homes, there's nobody has to go anywhere, do anything. It comes to you, you do it, you send it back. And so I think that was very effective to a limit of all the people that are sort of willing to do it. And then there's another subset of people that have questions, concerns, fear, you know, mistrust of the institution. And I think to sort of intervene upon them, I think it takes things that are probably more labor intensive, you know, like navigators, discussions, shared decision-making, all that kind of stuff. So I think that's our hypothesis. I think we have to sort of learn a little bit more, but I think you are right that, you know, if you offer too little, you know, and all these like sort of little interventions that may not necessarily work. The other part is that it may devalue it. So they might say, oh, it's only, you know, saving my life or reducing my chance of dying from colon cancer is only $10. Like, I don't want to get that done. We know that patients like to go to providers that are actually more expensive if they have a higher cost, because they perceive them to be, you know, more effective and, you know, a sort of you know, get better services. I think in terms of the choice overload, I think you're right that there might be this sort of perceived efficacy, but when we sent people the FIT kits, 30% of people participated. You know, and so that's the study that I want to do later on, and we are doing in a different population, which is to compare, you know, among people that have, you know, been offered colonoscopy, which most of these patients are, to compare just sending them the FIT kit, which is what some people might do, or sending them a FIT kit and saying, you can also get a colonoscopy as well. And then to see, because if you get a colonoscopy, you still get part of that sort of that 30%, and to see if there's a difference in that participation. So I think that might be the definitive study to show that. And just to see if, you know, because it should be no less. By adding colonoscopy from a sort of traditional economic perspective, it should be the people that want colonoscopy would get it and not get fit, but there shouldn't be a decrease in overall participation if we sort of follow that traditional theory.
Thanks. Great talk.
Thanks.
Thanks everybody for coming, and I think a lot of people had to jump off for other meetings.
Thank you so much. Have a nice day.